Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. Last time we have discussed the ABG, in which we concentrated on oxygenation. Oxygenation is measured by the partial pressure of oxygen in the artery, otherwise called the PaO₂. They calculated saturation of hemoglobin percentage which is oxygenated, that is the SiO₂. So SiO₂ is almost equal to the SpO₂. SpO₂ is the percentage saturation of hemoglobin obtained by pulse oximetry. Today we will be discussing the calculation of alveolar arterial gradient. So what is this alveolar arterial gradient? So if you look at this is the alveoli and here is the capillaries. The pressure in the artery is the PaO₂. That is the partial pressure of oxygen in the artery, and that is easily measured by the ABG machine. The pressure of oxygen in the alveoli is the PaO₂, written with the A is the capital. So the PaO₂ and PaO₂ in the artery, that is the alveolar oxygen and the arterial oxygen in ideal situation should be equal if it is diffusing properly. But in a normal person, and even in the normal lung, there is a mismatch between ventilation and perfusion. Some of the alveoli are ventilated more and some of the alveoli are less perfused. So this leads on to a normal difference between the arterial oxygen and the alveolar oxygen. This gradient changes with the age of the patient and diseases of the alveoli. Of course, it is influenced by the partial pressure of carbon dioxide in the alveoli and also the inspired oxygen concentration. So these are 3 points, remember. The AA gradient depends upon, one is the FiO₂, that is the inspired oxygen, the inspired air, what is the fraction of oxygen. Second is the amount of carbon dioxide at the PaCO₂ in the alveoli, and third is the age of the patient and the function of the alveoli. So you can basically say that the AA gradient determines the oxygenation efficiency. So this is a measure of the oxygenation efficiency. The difference between alveolar, that is PaO₂, and arterial oxygen helps in identifying hypoxemia. What is the cause of hypoxemia? Hypoxemia is the reduction in the oxygen in the artery, whereas hypoxia is the decreased oxygen in the tissues. The details and the difference we will discuss later. So now we are going to how will you calculate the AA gradient. The PaO₂ is measured in the ABG, that is partial pressure of oxygen is measured, but the alveolar PaO₂, that is alveolar oxygen pressure, is calculated by using the Alveolar Gas Equation. So if you look in the alveoli contains oxygen, nitrogen, and some amount of water vapor and carbon dioxide. So the pressure of oxygen, or the pressure exerted by oxygen, is the alveolar oxygen tension. So this is calculated by multiplying FiO₂, that is the inspired oxygen concentration, with the atmospheric pressure. But remember, the alveolus contains water pressure, moist also, so that is approximately 47 millimeters of mercury. And the normal sea level, the atmospheric pressure is 760 millimeters of mercury. So, and the alveolus contains carbon dioxide, and you have to minus this carbon dioxide pressure from this. So PaCO₂ divided by the respiratory quotient. This is how you calculate the alveolar gas equation. So alveolar gas equation is FiO₂ into atmospheric pressure minus the water vapor pressure minus PaCO₂ divided by 0.8. So this can be calculated simplified as 150 minus the PaCO₂ divided by 0.8. So if you subtract the water pressure, that is 760 minus 47, and multiply with the FiO₂, that is 0.21, is the atmospheric pressure. This comes to 150. So this is the simplified formula for calculation of the alveolar oxygen tension. So I will repeat once more. FiO₂ is the fraction of inspired oxygen, 0.21. Patm is the 760 millimeters. The water pressure is 47 millimeters of mercury, and the PaCO₂ is calculated from the measured in the ABG, and R is the respiratory quotient. That is the respiratory quotient. So now we are able to identify the PaO₂. So from the PaO₂, you partial pressure of arterial oxygen is subtracted, and this becomes the alveolar arterial gradient. Hope this point is clear to you. So we will see an example. Let the PaO₂ be 80, that is a PaO₂ 80 millimeters of mercury, PaCO₂ 40 millimeters of mercury. What will be the PaO₂, that is the partial pressure of alveolar oxygen? From the formula you can see 150 minus 40 divided by the respective quotient, 0.8. This is equal to 100 millimeters of mercury. So alveolar, the A gradient, alveolar arterial gradient will be 100 minus the PaCO₂, that is 80, is equal to 20. So hope you understood how to calculate the alveolar arterial gradient by using the alveolar gas equation. So again, I have already mentioned that the normal AA gradient, that is alveolar arterial gradient, depends upon many factors. One among them, very important, is the age of the patient. Age is an important factor. The normal is taken as less than 10. Or we can take it as 5 to 15 millimeters of mercury is taken as the normal. As age advances, it increases. There is a simple formula for calculating the AA gradient in as per age. Age divided by 4 plus 4. is the alveolar-arterial gradient. For example, suppose somebody is at the age of 40, it becomes 40 divided by 4 plus 4 is equal to 10 plus 4 is equal to 14 millimeters of mercury. So the first concept you should understand, AA gradient depends upon the age of the patient. As age advances, it increases. So we will look into an interpretation. When the AA gradient is more than 15 in a normal adult, what does it indicate? Another question is, the AA gradient is less than 5, but the PaO₂ is less than 70. These are the two situations you can get. That is, a patient with the PaO₂ decrease, that is hypoxemia, one has got a normal AA gradient and other has got high AA gradient. Normal AA gradient means the diffusion across the alveoli is normal. So what can be the situation? The classical condition will be hypoventilation. So hypoventilation, the alveolus is normal, so the AA gradient will be normal. Suppose the AA gradient is high, that means there is a ventilation perfusion mismatch, that is BQ mismatch, or it may be due to shunting or diffusion defect, that is problem with the alveoli. So what are the common causes for AA gradient increased with hypoxemia? First and foremost, diffusion disorder, that is problem with the alveoli, ARDS for example. Second is shunting occurring, intrapulmonary shunting. Third is ventilation perfusion mismatch that occurs in pulmonary embolism, consolidation, etc. Hope you understood this concept. So let us take an example. This is a 35-year-old patient admitted with opioid overdose. PaO₂ is 60, that means that's hypoxemia. PaCO₂ is 60. So what will be the PaO₂ by calculation? What we have already said, 150 minus 60 divided by 0.8. It comes to 75 millimeters of mercury. So AA gradient will be the 75 minus the PaO₂, that is 75 minus 60 is equal to 15. So the AA gradient is normal for the age. You can take it as 5 to 15 can be taken as normal. So this is suggestive of hypoventilation and is consistent with the clinical setting. Patient is not having morphine poisoning. So this is the first concept regarding the, or a very important point regarding the usefulness of AA gradient. The second thing you should remember is the AA gradient depend upon the FiO₂ also. So this is the alveoli. Suppose the inspired oxygen concentration FiO₂ is decreased. Naturally, the diffusion of oxygen to the artery, that is PaO₂, will definitely be decreased. So that I can develop a hypoxemia. And in ventilator settings, patient with hypoxemia, you give supplemental oxygen. Then the PaO₂ will be, that is the partial pressure of oxygen in the alveoli increases. If there is a problem with the diffusion, the PaO₂ will not increase accordingly. So let us take an example. A patient with ARDS is on 40% oxygen. That is the FiO₂. We are increasing to 40%, so it will be 0.4. And so what will be the PaO₂, that is the partial pressure of oxygen in the alveoli? We can calculate by 0.4, that is FiO₂, into the barometric pressure minus water vapor pressure. So 713, that is 760 minus 47 minus, we look at the PaCO₂. The PaCO₂ in this patient is 40 millimeters. So 40 divided by 0.8, that is the respiratory quotient. This will come in approximately 203/35. So the alveolar pressure of oxygen is 235 when you are giving 40% oxygen at sea level. Now look at the PaO₂. The PaO₂ of the patient is 150. So what will be the A gradient? 235 minus 150 is equal to around 85. So here the AA gradient is increased. So what does it indicate? This indicates that there is a problem in the alveoli. There is a diffusion of oxygen across the alveolus is not functioning properly. This classically occurs in pulmonary embolism. I will explain this with an example. Let us see this case. 50-year-old patient admitted with suspected pulmonary embolism, is having breathlessness, is the PaO₂ is 120. There is no hypoxemia, actually there is a hyperoxia. PaCO₂ is 30. So what is the PaO₂? Alveolar oxygen tension is equal to 0.6 into 713. That 713 is 760 minus 47, the water pressure, minus 30 divided is the partial pressure of carbon dioxide, PaCO₂, divided by the respiratory quotient. this will be equal to around 390. So what is the PaO₂ separation? PaO₂ is 120. So AA gradient is 390 minus PaO₂, that is 120, is equal to 270. So patient has got a high AA gradient. Patient is on 0.6 FiO₂. So this is a typical example of a VQ mismatch and is consistent with the pulmonary embolism in the appropriate clinical setting. So now we look into what are the clinical applications of this. The clinical uses are mainly to identify the differentiate causes of hypoxemia. That is a major function. That is, what are the causes of hypoxemia, or what are the causes where the PaO₂ is decreased. Normal AA gradient and PaO₂ is decreased, always suspect hypoventilation. Normal AA gradient. Increased AA gradient, we think BQ mismatch, shunt, and problem with the diffusion across alveoli. And this AA gradient calculation will help you to adjust the oxygenation and oxygen therapy, useful in diagnosing or considering pulmonary embolism, ARDS, pulmonary fibrosis, and pneumonia. So let us summarize. The take-home messages are: AA gradient helps to assess the oxygenation efficiency. That is the most important point you remember. This will help you to identify problems with the oxygenation or the efficiency of oxygen across the alveolar membrane. Secondly, the normal AA gradient increases with age. You remember, age divided by 4 plus 4 is the age. And the FiO₂ and PaCO₂ also influences the AA gradient as you know from the Alveolar Gas Equation, which is equal to PaO₂ is equal to FiO₂ multiplied by partial pressure atmospheric minus water pressure, vapor pressure, minus PaCO₂ divided by respiratory quotient. So when the FiO₂ is increased, or when the PaCO₂ is increased, there can be changes in the PaO₂, that is the alveolar pressure. Hope this was useful to you. Stay tuned for more videos on interpretation of ABG. Thank you.